So what is the model? So for years, value-based care models really have been either voluntary or pushed onto primary care, right? ASM is a huge departure from that. It is mandatory, being that, and I'll show the map in a second, that Medicare basically, with a stroke of the pen, decided which cardiologists are going to be involved in this, and, is aiming it directly at specialists, as you might imagine. Real quick aside, there are two initial chronic conditions, or conditions really, that are being used for this first initial period of the ASM. There's heart failure and there's low back pain. Given that this is called ASM Crash Course for Cardiologists, you could probably guess that we're going to be spending all of our time on heart failure versus low back pain, but just know that that's there too. The goal of this whole program is upstream management. That's a sort of a word used or term used relatively often. The idea being you're trying to use an outpatient setting to sort of stabilize and push, the onus onto the outpatient or ambulatory cardiologist to shift from episodic visit-only care to like continuous tracking and adjustments, trying to intervene before there's an acute or really an expensive sort of crisis or exacerbation. Participation is mandatory. They decided who's going to be doing this. I'm guessing, looking at the names in the list, quite a few of you are on, I recognize from the other list of folks who are required to be a part. One big thing here is that this, out of all the value-based care programs that have been sort of pushed recently, or even not recently, ever, there's some bite to this one. It is clinician to clinician, right? So it's focused on each individual cardiologist. And you're looking for 2027, a 9% increase or decrease on every Part B claim. So not just your heart failure claims, but what will Medicare pay you up or down 9% for every single Part B claim that you have. And finally, it's graded on a curve. So it's not, some parts of this are not entirely clear what is a good score or a bad score. You are benchmarked dynamically against other regional peers. So it's not a fixed target, which makes this sort of some of these other value-based care programs, you could sort of hit the benchmark and say, okay, wonderful. This year, it's a competition, right? And that's by design. So my friends who are on the mandatory list, how do they pick you? I won't spend too much time on this, but it's important to sort of just have an idea at least. So they went through and they took a bunch of census statistical areas and they basically selected, so they're not at random, but there was a random aspect to it of the selection of the geographic areas, determined through a retrospective analysis of Medicare claims who has enough heart failure patients, right? At least 20 beneficiaries with heart failure during a 12-month period, back-looking period. And then deciding which geographical areas count. And if those two things align for you, you are on the mandatory list. So that is reassessed. So those participants have already been selected for 2027, right? When you get the slides after this after this webinar, you'll see ASM participants as a link. You can go and you can check to see if you're on the list. That said, it's an annual reassessment. So it changes. Let's say you no longer, it's not like a locked-in event, right? You're not in it for 5 years. This model is 5 years. But if you drop out of eligibility, you can drop out for the following year. Or not drop out, but you're taken out of the mandatory aspect of it. So with that, so the truth is that, especially the folks that are on this call, if you're a cardiologist doing any heart failure, or like a meaningful amount of heart failure, or even a non-trivial amount of heart failure, you're probably in it for the long haul, right? Because it's only 20 original Medicare beneficiaries with heart failure during a 12-month period. And if you're not moving from region to region, you're maybe not stuck, but stuck. So something to keep in mind. CMS sees this as a scalable prototype. They're saying they're targeting two expensive things, heart failure and back pain. And they're saying, okay, we're going to see if this thing works. And if so, we're going to expand it to oncology and pulmonology and endocrinology. So depending on whether or not you love the model or hate the model, misery will have company if it's successful or vice versa. The idea really is to expand, and they've done that before and tried these things before, but never quite as pure benchmarked as this, right? It's really, it's grading on a curve. It's truly, truly grading on a curve amongst peers. So, high stakes, 9% up or down. Not bupkis by any means, right? How is it measured? How do they decide who gets who gets +9, who gets -9? So there's two main categories and then two sort of secondary categories as to how they're going to measure performance. Now, you might be used to some of these models where it's clinic based or like group based. This is so there are some of these categories are based on sort of clinics because it's talking about EMRs and things like that. But at the core, you're being judged based on one physician or really one physician, right? You. Whatever the MPI is, it is everyone could have different scores, even if they are across the hallway in the same practice. So the two main categories are quality and cost. Quality really is they pulled out a bunch of measures that you might already be familiar with from MIPS and said, we are going to make these 5 mandatory quality measures that everyone has to utilize and track. That's 50% of the weight, up or down. On top of quality, so those are specific measures. Next slide, I'll go over those. On top of quality, there's a cost aspect, and this is a little bit new too. They're saying, okay, patient has heart failure. We are going to add up every single claim during the episode of heart failure, which is and afterwards, and we are going to use that as a benchmark of success. So we're all used to some extent like these measures trying to be the measures are always trying to get at lowering costs, but this is super clear. It's like you cost us more money during the heart failure episode and afterwards, we're going to count it against you. You cost us less money, we're going to count it for you. So suddenly, all the different interventions that you do, you have to take into mind and say, okay, and we'll go more into this in sort of a future slide, but RPM is $500, right? And maybe that'll save a $30,000 hospital and post-hospital spend. So you have to weigh it now, because that $500 that you're billing, visits, anything that you're billing on that patient is counting against, not against, but it's being added up towards that patient's total cost. Now, the big deal here is every admission in the hospital is like, we're talking $100 visit versus $20,000 admission, right? So there's still sort of the big lever, which is readmissions, but everything counts in, right? So it's important to weigh intervention and procedure and all that other stuff against the actual cost of doing it and the cost savings. Then there's two secondary things, and really these are sort of binary. Medicare is saying, you got to do these or we're going to count it against you. First is care improvement. Care improvement has two things. They're saying every single patient needs to have a health-related social needs questionnaire done. We want you to do socioeconomic, health-related needs, screenings. You are going to attest that you're doing it. And the other thing is, we want you, cardiologists, to go to the PCPs for these patients, and we want you to attest to us that you're signing collaborative practice agreements with the PCPs. You do these, congratulations, we are not going to reduce your score. You don't do these things, and we're going to reduce your score up to 20%. Just a quick aside, collaborative practice agreement is an agreement with the patient's PCP that has like data sharing, co-management, care transition information. They're relatively low lift, but you still have to. It's something you got to do, right, to be able to meet that criteria. And then finally, improving interoperability, which really is, do you use a certified EHR? And the vast majority of groups at this point are using a certified EHR, given MIPS and meaningful use and all the other stuff that goes behind the scenes of that over the years. But if you don't, negative 10%. So that is how this works. You have two main categories, quality and cost, and then you have the two sort of subsets of do what we say or we're gonna strike you down a little bit. There is one thing on here that actually we didn't put on, which we probably should have. There's a small practice adjustment of 10 or 15%. where if you're in a small practice, they're giving you a bit of a, actually, this is a relatively recent announcement, but they're giving a bit of a boost to small practices who might have more trouble meeting these criteria. And, you know, we'll when we do the follow-up, we'll include something about that too, because we probably should have had some citations and stuff like that in here, in hindsight. So first of the two things is the performance measurement, right? And this factors into that quality side. They picked out 5 measurements. These are probably, or maybe, looking at things that you've already known about because of MIPS, right? And other value-based care programs. So first, this is a mandatory scorecard. It's not like MIPS where you can be like, I'd like option 1 and 7. Nope, these are the ones. If you have been selected for mandatory participation, you're being judged on this, whether or not you want to be. So really quick to go over them. The first one, readmissions. How many unplanned cardiovascular-related hospital admissions attributed amongst your heart failure patients? Now, it's interesting because this really is not specifically heart failure admissions. It's anything cardiovascular with a patient with heart failure. The majority is going to be heart failure rates, but just something to keep in mind. Those are that is the worst thing to happen, as you might imagine, because this is hitting you not just there, it's hitting you on the cost side, because every one of those is between 13,000 at best case scenario to 2030 if there's a lot of follow-up needs and more medical care needed afterwards, right? So the sort of overarching theme here is do everything you can for your patients to get care at a lower acuity, lower cost center before they need to go into the hospital, mostly for fluid retention. So controlling high blood pressure is the next one. This one's an easy one. The percentage of adults diagnosed with hypertension whose blood pressure is adequately controlled during the measurement period. One caveat to this, though, is that if you have no measurements during the period, it counts as a big old 0. So, one, you have to make sure that you're doing a good, which I'm sure everyone here is, but it's not just making sure that patients are compliant and taking their medication and titrating appropriately, yada, yada, yada. It's also making sure that you have measurements in your EMR or in some system, right, that you can use for reporting that makes it clear as to what that is. Because a 0 doesn't look good if there's no measurements that have been taken. Then there's 2 that are basically just, are you following guideline-directed medical therapy, right? Are you prescribing things for ventricular dysfunction, right? And that's just a yes or a no, right? Or excuse me, it's not a yes or no. It's how many patients are appropriately treated based on those who have the 2 conditions, right? And then finally, is slightly new, is a functional assessment for heart failure. So this, I guess it's not new, but this is a PROM, right? A patient-reported outcome measure. There's 2 really, really common ones. One's the Kansas City cardiometabolic, cardiopulmonary questionnaire, but basically it's a patient-reported questionnaire. They want you to now go through and have all your patients with heart failure take at least one, and then you're rated on that as well. So those are the big things. Those plus cost, right? So this is what you're being graded on, and then just general cost. And they're 50% of the equation each.